Everyone, hope you're all doing well. I appreciate you accommodating my needs for tomorrow's class, and hopefully this won't be too painful for you to have to watch this video. Um, welcome to my office here in my home in New York, my partially moved out of home. This is where I used to work half of the week from before we moved down to Pittsburgh. Um, so we're going to talk a little bit about this is the information from chapter 9 out of our textbook, and this info for this week is actually one of the things that I did in my previous life. Finance, reimbursement, patient financials is really a lot of what's at the heart of compliance work. But even before that, I did work in finance. So a lot of this information is what I used to do. So a lot of personal experience that I've had in this work, and it really is. And I put in the announcement this morning in the Blackboard classroom, and it really is without finance, without reimbursement, we wouldn't be able to keep the doors open. So it is really important to what we do in healthcare to make sure that we are appropriately financing the operation. A lot of people think that, oh, it's just bean counters and boring stuff, and it is. I mean, it is that's really what it is. But it is so important to have this aspect of the operation, to have really highly qualified and talented people working in that for two reasons. Number one, because you want to make sure you have the most qualified folks doing the best job for you. So you are bringing money in the door so you can keep providing great clinical care. But number two, your compliance risk is highest in your finance area, your billing and coding, your financial accounting risks, those types of things. So if you don't have highly talented people, they may be making errors, mistakes that could ultimately become a fraud and abuse issue, therefore get your company in trouble, ultimately leading to large fines, etc. So you really want to have highly talented folks working in the finance area. So we're just going to talk about, there are a bunch of slides. I may breeze through some of them. I don't want to keep you on this video for 100 hours, but there's quite a bit to go through. So keep in mind that from a health expenditure standpoint, there are the bulk of our costs do go to our clinical care. So the biggest bulk is for hospital care, about 30, and this is going back a few years, but it hasn't changed a great deal. So the biggest bulk of expenditure does go toward hospital care. It's very expensive, and so the bulk of our money goes toward hospital care, 32%, another 20% toward physician and other clinicians, so non-physician practitioners, etc. Um, and then 9%, there's always an outcry over the cost of prescription drugs. That really isn't what costs so much. They do cost a lot. They cost more than they should. And we could decrease our expenditures in that area, but that is certainly not. Hospital care is what costs so much. We need to keep people out of the hospital to decrease our costs. But as we look at all costs, those five areas cost more than 75%. Only about 24% of spending goes into things like administrative costs, equipment, structures, research, those types of things. So the bulk of our costs do go into clinical care, and a lot of that on the hospital side. So when we think about how these things are paid for, a lot of this is paid for by insurance. So we're going to spend a lot of time in this presentation, in these slides, taking a look at insurance and various types of insurance, how we're trying to cut costs, those types of things, because those insurers, be it a government insurer, various types of commercial insurers, those insurers are really what are trying to cut back those costs and get, though, even though it's 32%, maybe it may be 32% of a lesser total expenditure. And so how can we drop those costs down a little bit? So when we think about sources of payments overall, you can see the big bulk of funding when you look at if you were to look at the total source of payment for a single facility, about half, and that is actually even low for if you were to look at a single facility. For some facilities, half is going to be low. For some facilities, that's going to be high. But so generally, um, overall, for an entire for the whole country, about half of their payments are coming from public sources. So Medicare, Medicaid, and CHIP or SHIP with the S in the front, but CHIP, which is the Children's Health Insurance Program. So public sources, and we'll talk about Medicare and Medicaid. When folks are first getting used to those two programs, they get them confused quite a bit. We'll talk about the difference between the two. But Medicare is for older folks, Medicaid is for low-income folks. Children's Health Insurance Program is obviously for kids. But those three programs are bringing in the bulk of your dollars in your hospital system. If you were to go to a place like, I'm not really super familiar with Pittsburgh area hospitals, but a Pittsburgh area hospital that is in a more indigent area, their public funding source of payments are probably going to be more in the 70 to 75% realm. If you were to go to a Pittsburgh area hospital that is in a more affluent area, their public funding payments may be a little less, but not a lot less, because they probably still have a very high Medicare population, because the bulk of your inpatients are going to be older folks over 65. They're going to have Medicare. So it's still always going to be right around that 40 to 49% mark, even a very affluent area, because hospitals tend to be most folks going to the hospital are older for inpatient stays. 32% is for private health insurance. Private health insurance is folks that have coverage through their employers, or it could be folks that have coverage through what has become known as the Obamacare plans, although I don't like calling them that because that's a kind of a layperson term. It's through what are often known as the health exchanges. So those plans where you go down, you sign up, you don't have coverage through an employer, you're not eligible for coverage through Medicaid, you're kind of in that in between, you might be self-employed, so you used to buy private health insurance maybe from a broker, that's not available anymore, so now you have to go down, you buy through these health exchanges, which are state-run organizations, but they're private health insurance. You buy this plan, and then you have access to coverage through this health exchange program. So, so they are what came about as part of the Affordable Care Act. So that is considered private health insurance, just like a group health plan you would get through an employer. So that's about 33%. Out-of-pocket payments are just payments that are coming in, either a co-payment that you have from your private health plan or from Medicare, or if someone's paying self-pay. Maybe I'm going in to have my facelift or my liposuction. That's going to be straight up self-pay. My insurance isn't going to cover any of that. Or it could be someone that doesn't have any insurance, so they just have to pay out of pocket. So that's going to be an out of pocket payment. And then investments, if a hospital may have monies that they'll take and they'll set aside and invest in certain things, bonds or whatever, those investments will be coming back in as sources of payment as well. So some of the things that have caused changes that have created this evolution in the industry, more comprehensive benefits. There have been quite a few changes in benefit structure, and we'll talk about that. Probably the most recent change that has really caused an evolution in health benefits is the creation of the high deductible health plan. It's created a more consumer-driven, really created the notion that folks have had to be cognizant of their own healthcare services that they're going out to get because they are going to have to pay for it. So it really has evolved the industry a bit. Um, the role of public and private sectors in healthcare coverage. So those health exchanges I was just talking about, how it's not just about people that are self-employed. They may have been self-employed for years and they've always just bought private health insurance. Now there is this interaction between the public and private sector, even for folks that are self-employed. It's not just Medicare, Medicaid folks going and dealing with the government. Um, now there's more of that interaction, and also there's more public-private sector interaction with regard to promotion of population health. So we're seeing public health folks get involved in the private sector, insurers trying to promote wellness and create a more healthy population overall. Health insurance as an employee benefit. So obviously this is a huge employee benefit. We talked about that in the HR week, but continuing to promote health insurance as a benefit overall. Way back, many, many years ago, it wasn't a benefit. It wasn't something people really worried about. Now it is a key and crucial benefit for folks looking for work. Changes in reimbursement. Obviously, there was a time when WellCare wasn't reimbursed, when things like birth control, family planning overall, things like infertility treatments, none of those things were reimbursed, and now we're seeing all of those things become as covered services under plans. So that's important. A shift from fee-for-service to managed care. We'll talk a little bit more about that when we talk about the types of insurance, but fee-for-service is literally paying a fee for the services rendered. So I go and have a $100 office visit, insurance company pays $100, whereas managed care is what that sounds like. Doctor orders an MRI, the insurance company says, let me look at that MRI. They have more of a hand in the care that's being provided. They are managing your care. And then obviously just this continual cost and the rise in the cost of healthcare. So lots of legislation has had a hand in changes to health insurance over time. There was, way back in the 30s, there was a discussion about making changes to health insurance. There was a call for national health insurance, and that's actually when the Medicare, there was a call for Medicare at that time. There was a call for Medicare for all at that time, but also there was a call to move to providing Medicare. And then, but there was a lot of opposition to it. As the slide says, it was seen as socialized medicine. Nobody wanted to do it, so it was not enacted. And then finally, people started to move toward a more positive view of it. And in 1965, Medicare and Medicaid were enacted. Medicare, again, is the program that provides service for those that are older. And there's a few other areas that are covered, and we'll talk about that later in the presentation. Medicaid is for those that are of low income, and we'll talk about that a little later as well. So Medicare, Medicaid, 1965. And then the Children's Health Insurance Program, that was came into play when the Clintons, specifically Hillary Clinton, had put together her own kind of national health insurance plan that she was trying to put forward, and that kind of fizzled. But secondary to that legislation, well, it wasn't legislation because she was the first lady at the time, but secondary to that movement, they did come up with, the legislators of the time did come up with the Children's Health Insurance Program, which helped those folks. The problem was Medicaid was not providing coverage. There was this missing vulnerable population of kids that were not getting coverage. They weren't eligible for Medicaid, but they weren't getting covered. So that was really, driving force to get the Children's Health Insurance Program started back in 97. So Children's Health Insurance Program legislation back then, and then obviously PPACA or the ACA, Patient Protection and Affordable Care Act, was passed in 2010, which is what is commonly known as Obamacare, was passed under the Obama administration at that time, and is still in place. There's been a lot of the Trump administration has made a couple changes to it, and there's been a lot of push to try and repeal and replace, but there was originally just repeal, and then there was repeal and replace, but they've made a few changes, like with the individual mandate for coverage, but it has not been. It is still in place, so there really hasn't been any significant change to it. So a few terms, I'm not going to go through every single one of these. I'm sure you all groaned when you saw this slide. But a few terms on here that I think are really important that you want to know. I'll go down to the cost sharing. You'll get to learn about risk pooling and, I'll mention risk pooling. So risk pooling is, in health insurance, what happens is you'll have, especially in group health plans or in any type of plan, but especially, so we'll talk about group health plans. So in a group health plan is I'll just use RMU for example, because I'm not on the RMU coverage. So, but I am eligible for it. So at RMU, all of the employees are eligible for the coverage at RMU. And so at RMU, you have employees that are in their early 20s, and you have employees that are in their probably mid 70s, and you have everybody in between. And you have single people, you have married people, you have families that have young children, you have families that have children that are reaching the age of 26, at which point they have to come off the coverage. So I have all gamuts of people on this. So what this means, what risk pooling means, is that type of coverage is creating a risk pool. In risk, in insurance, means that you're taking a certain amount of risk, which means that, trying to come up with a good way to describe it, when you set the premiums for a plan, so premium is how much you're paying out for your coverage, you're setting the premium, and then it's kind of like a bet. So you're taking a bet that the amount of payout that you'll pay out in insurance on all of those people will remain about equal to, hopefully less, that's the bet you're taking, hopefully less than what you're taking in premiums. And so by risk pooling, you're bringing together all of these people. You're putting them in a risk pool. So you've got people that are probably very well. Generally, you're going to see probably the younger people, probably the bulk of the families with young kids. Most of the young kids probably going to be well. And actually, most people of middle age generally pretty well. Maybe a couple of folks with chronic conditions or whatever, maybe hypertension, diabetes, generally pretty well. But you're pooling risk because on this end up here, the older population, they're probably not as well. This is when people are beginning to have chronic conditions that are affecting their health to the point where they are seeking more healthcare services. So by pooling all of these people in that big, we'll call it the RMU pool because it's RMU group health coverage, we're pooling them all together. So the risk is balanced. So the risk that you're taking is that the low expenses you're paying here is offsetting the higher expenses you're paying here because everyone in this pool is going to pay the same premium. So that's the concept of risk pooling. And it's important to keep that in mind that, that everyone's going to pay that same premium in that pool. You'll see that same type of, similar type of application to car insurance. So if you, let's say you've had an accident, you may be placed in a risk pool if you need to get new insurance, you may be placed in a risk pool with others that have had accidents, and your insurance premium may go up. Or if you're lucky, you may go to an insurer that has more trust in you, and you may be placed in a risk pool with others that haven't had accidents, and it may keep your premium a little bit lower. If you had an accident, your premium is going to go up, but it depends on how they pool their risk. So generally, in healthcare and health insurance, by pooling you in a big risk pool with some folks that'll have higher expenses, some folks that'll have lower expenses, your premium will stay steady. Now, it's likely going to be higher than your expenses if you don't have many, but hopefully you'll stay with that plan. And then when your expenses go up, your premiums will be less, so it'll balance out. That's kind of the concept of risk pool. Fee-for-service payment, we talked a little bit about that. That's truly a type of program where you'll see a physician. It'll cost $50 for an office visit. The insurer will pay $50 for that office visit, or approximately $50. So that's how that works. That's a fee-for-service type of payment. A prepayment form of payment is a type of payment structure in reimbursement where the insurer will make a payment that it's often known as capitation. So they'll make a capitation payment to typically a physician. They'll pay the physician a certain amount per member per month. Typically, it's called a PMPM payment. So they'll pay the physician maybe $100 per member per month, or $50 per member per month. And that covers all the services that you might receive from them that month. So if you go in to that doctor 5 times that month, or if you don't see that doctor all year, he's going to receive $50 a month for you. So that's what's called capitation, and that's another form of risk for that physician. So if you do come in 5 times that month, he's not making any money on you. But if you never show up during that year, he's making a bunch of money on you. So it's another way of risk sharing between the insurance company and the physician practices. That type of payment, that prepayment or capitation, that is common in HMOs, and we'll talk about HMOs. Cost sharing, co-payments, deductibles, co-insurance, very important in insurance. Co-payment is typically when your insurance is paying on a percentage. So and I'll rewind a little bit. So oftentimes if you have a plan that's going to pay on some kind of a percentage, you'll have a deductible. So your deductible will say be $100. So the first $100 of your expenses you will have to pay. So that'll be your deductible. And then you will have to, after that, your insurance may pay 80% and you have to pay 20%. That 20% is your co-insurance. And then a co-payment is maybe an amount that you will pay just when you go to the doctor. So you may have a $25 co-payment that you just always pay the $25 when you go to the doctor. So sometimes you'll have plans that work on a co-payment, and sometimes you'll have plans that work on a co-insurance. The co-insurances are percentages. The co-payments are typically dollar amounts. So it all depends on how your plans are set up, and it can vary. Policy limitations are what they sound like: maximum out-of-pockets or lifetime dollar limits. Typically, lifetime dollar limits, most have been eliminated under the Affordable Care Act, but it depends on what type of limit it is. So different types of benefits: comprehensive benefits, major medical benefits, catastrophic coverage benefits. That is, there are certain types of catastrophic coverage benefits that are available for, like Medicaid has a catastrophic coverage benefit in some areas where if you do not have coverage and you have a major catastrophic injury. Let's say you do not have insurance coverage at all. You have a major catastrophic injury, major car accident, something of that nature, and then you can, in some states, you can apply to Medicaid for catastrophic coverage, and receive help with your medical bills. So that's an option in some cases. Medigap we'll talk about a little bit. Some plans have disease-specific or long-term care coverage as well. So those are a couple options. Some concerns related to health insurance. Some people are concerned about their choice of provider. So this is a huge issue for those of you that are from the Pittsburgh area or live in the Pittsburgh area. This is a huge issue in Pittsburgh. So there was a rift for those of you that aren't from the area. There was a rift several years back between the Allegheny Health Network and UPMC. And Allegheny Health Network is owned by Highmark, which is an insurance company, and Highmark and UPMC got in a tiff, and they UPMC refused to contract with Highmark anymore. So it created a problem in that people that had Highmark Blue Cross and Blue Shield insurance could no longer go to UPMC facilities, and then vice versa. So long story short, people that have Highmark Blue Cross and Blue Shield coverage generally cannot go to UPMC facilities, and people that have UPMC health plan can generally not go to Allegheny Health Network facilities. So same issue back and forth. This is problematic when it comes to choice of provider, because you may want, I'm a good example. When I first came to Pittsburgh, I had Excellus Blue Cross and Blue Shield insurance, which is a provider up here in New York, or an insurer up here in New York. However, I was covered in the Pittsburgh region by Highmark Blue Cross and Blue Shield, their network. So I could not see any UPMC providers. And if you've traversed around town at all, you've probably noticed that that's the majority of them. So it's hard to find providers. And that kind of moves into the next bullet there, access to care. It's hard when the provider, when the providers of care don't play well in the sandbox together. So prior to that tiff, everybody participated with everybody. All of the all the plans worked well together, and I'm sure there was a lot of rivalry, but they still, for the good of the patient, still provided access. And then they had that issue, and now there's a big rift between the two. So it does decrease access to care, which is problematic. Restrictions on care. So health insurance can certainly restrict care, and I kind of alluded to this with the MRI example earlier. Managed care really does create a lot of concern with regard to restrictions on care, and can put in place a negative view of insurance when there is a concern that insurers are inappropriately restricting care. So sometimes that can be seen as problematic when it may be completely appropriate, but it can be seen as problematic when there's a concern that there is an inappropriate restriction of care being made by an insurer in those types of situations. And we'll talk more about managed care as well. Okay, sorry about that. So moral hazard, a little bit about that. Generally, moral hazard it's about the notion of having the focus of, if you have health insurance, you're going to use health insurance. So it's about the hazard, or the moral hazard, the concern of, okay, if we make everyone get health insurance, are costs going to go up further because everyone has health insurance. So, there's a concern there. Pre-existing conditions, that's really kind of been done away with under the current version of the ACA, but where the potential exists that could change. Buy downs, coordination of benefits, we'll talk a little bit further about that later on. So in the interest of time, I'm going to try and move a little more quickly. I stop there for a second because I know I'm moving a little more slowly than I'd planned. So I'll try and move this along. So types of health insurance, conventional indemnity plans, they are few and far between nowadays, but there are still some that exist. Those are plans that have typically a small deductible, $100, $150. Then after that, the expenses are paid at typically 80% is paid by the plan, 20% is paid by the insurer or the insured, the patient, and hospital expenses, so things like laboratory, radiology, inpatient stays, all paid at 100%. Indemnity plans are also what's known as Cadillac plans. They're awesome to have. I had one until just a couple months ago. Awesome plans to have, very few and far between, very, very expensive. So there aren't many of them around anymore. What's much more common are the others listed here on the slide. So HMOs, health maintenance organizations, PPOs, preferred provider organizations, point of service plans, and high deductible health plans. So let me see. So I'll talk about HMOs on the next slide, but I'll talk about a few of these others. PPOs are what it sounds like, a preferred provider organization, in that it's an organization of providers that will come together. They're contracted as a network to provide services to you, the insured, and it's typically, we talked about that co-payment. You typically will be responsible for making a specific co-payment to your provider when you go to see them. So it's often like $25 to see your primary care physician, maybe $40 or $50 to see a specialist, and then maybe $100 to go to the emergency department. They're usually set amounts to go to see certain areas, and then when you need services outside of that, that's when you have a deductible and a co-insurance, those types of things. So it all depends on the situation, but they are managed care plans, which means that if you want to go to see a specialist, you often need a referral. If you want a more expensive service like an MRI or a PET CT scan, you need a pre-approval from your insurance. If you need surgery, you need pre-approval from your insurance. So those are all managed care plans. Those are all elements of managed care plans. Point of service plans, POSs, are very similar in nature to a preferred provider organization. Usually a PPO organization is a network of physicians. A point of service plan is similar in nature, but they tend to be more working with integrated health plans. They're very similar in nature, though. There aren't a lot of differences between the two. High deductible health plans, this is really what most folks have today. And what a high deductible health plan is a plan with just that, a high deductible, typically in thousands. $3,500 is not unusual. So what it is you have your health plan. You'll have a really high deductible, and then you'll have what's called a health savings account in conjunction with it. So your health savings account, you'll put money into pre-tax. In some places, your employer will put some money into that as well. So you'll get a little bit of money from your employer that they'll go into that health savings account, and that will help to pay some of that deductible for you. But the key is that it is to create a consumer-driven health behavior. So you will not go to the doctor unless you need to. That's what they're trying to do, is drive those behaviors. However, what is covered under those plans without deductible is WellCare. So you can go to your doctor for your physical examinations, all of your WellCare, your screening exams, all of that stuff. That is covered and that is free. And it's not subject to that deductible. So if you have the sniffles, you're not likely to go, but you can go and get your physical exam, get your screening tests done. So that is the point of the high deductible health plan. And most places, that's what you're going to get nowadays. I know at RMU, that's what we are offered. Luckily at Duquesne, where my husband works, we have another option. So I'm not a big fan of the high deductible health plan because I do have some conditions that require me to get care pretty regularly. Sorry about that. Okay, so different types of HMOs. Closed panel, staff model, both pretty similar, and they are both models. Staff model is typically where the physicians are employed by the HMO. Closed panel, they may or may not be employed, but they're both HMOs where the physicians that are part of the HMO you are required to see. So you can only see these physicians, and they all work for or are tied to that HMO, typically in one building or in a few buildings that are owned by that HMO. Very restrictive and not as common nowadays because of the nature of health insurance and how people are somewhat migratory. So it's not really as common as they used to be when HMOs first came about. Group model, open panel, network model, IPAs, much more common. And these are all types of HMOs where the physicians that work in conjunction with the HMO are just physicians that are part of groups that have contracted with that HMO. And these are all different models in that the physicians are contracted with the HMO in different ways. So that's really all it is. And the difference between an HMO and, say, the preferred provider organization that we talked about earlier is just that the health maintenance organization is much more restrictive. In that you typically, if you want to see physicians outside of the HMO, you're either going to pay completely out of pocket, or you're going to pay a very large penalty. You may pay half of your visit. Typically with a health maintenance organization, you are seeing the physicians within your HMO and that's it. So HMOs are much more restrictive than, say, a preferred provider organization, the PPO, which will typically allow you to see physicians outside of the organization, the contracted organization. HMOs are much more restrictive. Also, HMOs are much more restrictive typically when it comes to managed care. So an HMO will require you to have a gatekeeper, or that a primary care physician that really manages your care. A PPO may or may not require that. So this is just some picture of how folks are split. This was in 2014. This is from our textbook. So in 2014, as you can see, the highest percentage of folks at that point were enrolled in the PPO type plan, with only about 20% enrolled in the high deductible health plan. This is health plan enrollment in those these types of private health plans. I would be interested to see numbers from, say, 2018 at the end of this year. I bet we would see a shift to those high deductible health plans because there aren't as many PPO plans being offered. But yeah, so interesting the shift. You can see the shift from conventional. Here's my cursor. This was the indemnity plans back in the 80s. They were very, very popular, and you can see the shift down to how hardly anybody, less than 1%, has access to that now. I won't go through this slide. You have access to this information, but this is social insurance. So Medicare, Medicaid, generally Medicaid. When we're talking social insurance, you're usually talking Medicaid, but access to the various aspects of the legislative history of social insurance. But so we'll dig into Medicare and Medicaid a little bit. As I said, Medicare is generally provided to folks over 65 years of age. Once you turn 65, you become eligible for Medicare, but it is also provided to people that are permanently disabled as deemed by the Social Security Administration. It's provided to people with end-stage renal disease and some terminally ill patients, typically those that are deemed appropriate by the Social Security Administration. In 2015, there were 55 million people on Medicare, and there are different levels of Medicare, Part A, B, C, and D. Part A is your hospital insurance, so this is what covers inpatient hospitalization and replacements for inpatient hospitalization, so things like home health care, skilled nursing facilities, things like that. So that's your Medicare Part A. Medicare Part B is what used to be deemed major medical insurance, but that's what covers things like outpatient hospital services, physician practice visits, things like that. So, but it's called supplemental medical insurance. But it's those types of outpatient type services. You can get what's called a Medicare Advantage plan or Medicare Managed Care, and that's called Part C, and that would replace your Part A and Part B. It is if you see ads on television or in magazines, newspapers for Medicare plans through insurance companies like United Healthcare or I think UPMC has one. Those plans are Medicare Advantage plans. So they are Medicare managed care plans that are being offered through commercial insurance companies. So those are they are taking over for the regular Part A. Part A and Part B are what are called traditional Medicare. Part C is managed Medicare. It's like a managed care plan. And then Part D is prescription drug benefits. So you can pick up the Part D prescription drug benefit. If you have Medicare managed care, most of those plans have the Part D benefit built in, but not all of them do. So some people also have to pick up Part D. Medicare is not free, by the way. You have to pay for it. Most people work throughout their lives and get Part A for free. But not everybody does. When you get a paycheck, you see that line that says Medicare. That's the money coming out for your Part A benefit. But Part B is not free. You have to pay for that. Or if you pick up a Part C plan, you have to pay for that. And Part D also not free. So Medicare is not free. You do have to pay for it. It's a sliding scale. So you can, if you have obviously most elderly folks do have a fixed income, so it's based on your income, but it isn't free and it's not cheap either. So it can be quite pricey. So various sources of Medicare revenues, we won't focus on that. Causes of growth in Medicare spending, there's a multitude of them, but I'll focus on a couple. The biggest area of growth in Medicare spending that I think anyway, and the book agrees with me, is the fact that we've shifted from a time when we were focusing on providing care to patients that were ill, acutely ill, and we made them well and we sent them home. And now we have such a huge population of folks that are older, and that population is growing. Baby boomers are getting sicker and sicker and older, and they're chronically ill. So we're shifting from that acute illness, send them home, they're well, to these chronic illnesses. These patients are living longer with these really chronic illnesses, and we're having to provide this chronic care to them. So there's many more of them. They're living much longer, and they have all these chronic issues. So that's part of the issue. We talked about the hospital expenditures. And one of the things that's not on this slide that I think is important is huge issues with fraud and abuse. Massive problems with fraud and abuse in Medicare, and it's really difficult to get that under control. And they're still trying, but it's a major problem. So some of the efforts that they've taken underway to try and control Medicare spending, these are all different types of reimbursement systems that they've tried to put in place. So on the inpatient hospital side, they've used what's called diagnosis-related groups, or DRGs, to try and adjust spending. And what these are is when a patient comes in for a hospital stay, instead of paying for all of the services that they had, they actually pay the hospital based on the diagnosis of the patient. It's a very convoluted formula, very difficult. I won't go into that, but it, most simply it's based on the hospital's the diagnosis and the procedure code. It's based on coding, so medical coding, we've talked about that. The diagnosis code and the procedure code. Primary diagnosis, primary procedure. Those two things go into a formula and they get paid based on that. So it comes out to a diagnosis-related group, or DRG. That's how hospitals are paid. It has nothing to do with the length of their stay, the number of charges, none of that. It's all based on coding. So coding is very important in that realm. Physician office visits are paid based on a system called RBRVS, or Resource-Based Relative Value Scales. And these are scales that were created by some folks from Harvard that actually put into place, they valued the level of work, the level of, it was a work component, a malpractice component, and what the heck is the other component? The work RVU, the malpractice RVU. It's probably in the book. It might not be in the book, though. Work, practice, malpractice. Work, malpractice, and work, practice, and malpractice. So work, practice, and liability, it says in the book. But work, practice, and malpractice go into this. Different levels, they assigned all of these components to it. And ultimately, what it does is give the amount of, it's just an arbitrary scale that they've created to create what's called a fee schedule. So, so that's how they've tried to fix the spending issues in the physician office visit realm. Ultimately, they've just created what's called a fee schedule. For skilled nursing facilities, they've created what are called RUGs, resource utilization groups, very similar to the diagnosis-related groups up above that we had mentioned. For home health, they've created what's called home health resource groups, or HHRGs, again, similar to the DRGs that we mentioned above. And on the outpatient side, they've created the hospital outpatient prospective payment system, which is called OPPS. And again, very similar to those DRGs above. It's a very similar system based on diagnosis procedures. So all of the systems are very similar except for the RBRVS, which is what's called a fee schedule. So all similar systems. In Medicare, probably the two biggest concerns are that the program continues to increase spending, and it's not going to remain solvent. The biggest the biggest joke or concern, it's not really a joke, but especially the presentations that I've done on fraud and abuse over the years, is that there's absolutely no chance that the Medicare Trust Fund will be around when I am there to use it. So it's not likely that it'll be around when you guys are there to use it either. But hopefully we can make changes to it so that it will be. But at this point, it's not likely that that money will still be around. So Medicaid. Medicaid is the other program. It's the other Medi program. So remember, Medicare for elderly, Medicaid is coverage for the medically indigent. So if you get SSI income, or whatever it happens to be called in your state. So if you get funding from your state, if you receive EBT payments, if you receive payments from your state in any way under their state welfare system, whatever it happens to be called, you are qualified for the program, for the Medicaid program. However, it depends on your program, because not every Medicaid program offers coverage to everybody. So if you are eligible for payments, you are eligible for Medicaid, but eligibility requirements are different, as far as some states offer coverage for only families. Some states offer coverage for pregnant women, children, and infants. Some, it just depends on what is offered in your state. So, but generally, there's a pretty wide berth of folks that are covered if you receive coverage, or if you receive those payments, monetary payments from the system. There was an expansion of coverage in legislation many years ago to allow for coverage for pregnant women, children, and infants, and then a wider expansion of coverage under that Children's Health Insurance Program. The Children's Health Insurance Program allowed families with higher incomes, higher with relation to the federal poverty level, for kids under that Children's Health Insurance Program. When they look at Medicaid eligibility, it's all based on a percentage of the federal poverty level. And so it's a higher level in relation to that federal poverty level to get kids covered under that CHIP program. So it's Medicaid's second largest social health insurance program. The largest is obviously Medicare. And there was a program expansion under the Affordable Care Act, but not all states offered that expansion. So some states decided to take the expansion money, and some states did not. So when on this slide, it shows that variation in cost sharing. This 50 to 77% of costs are paid by the federal government, and 23 to 50% of costs are paid by the state. It's normally a 50-50 split between federal and state, but not for those expansion dollars. Those expansion dollars were more paid by the federal government and less paid by the states. So, that's what's kind of got those percentages off a little bit. But generally, it's a 50-50 split between federal and state government. Federal government pays half, state government pays half. Medicaid programs are very expensive to operate. They're paid in the states out of your tax dollars. I'm not sure where the federal government gets the money for. I'm sure they're paid out of our tax dollars as well. So things that are legislated as mandated by federal legislation have to be covered: inpatient hospital stays, outpatient, physician services, lab x-ray, the kind of things that you would expect to see. But states can add things: dental care, mental health, drug and alcohol, rehab. You'd be amazed at things that are covered under some. In New York, there are things covered that horrify me in the Medicaid program, things that you would never see covered in any group health program. But they're covered under Medicaid. Kind of crazy, the things that they cover. But that's just what they've chosen to cover. Generally, I would think it would be fiscally responsible to cover what you see here on the screen, but they do cover a lot more than that. Here in New York, I'm not sure. I don't know a lot about PA's Medicaid and what they cover and what they don't. But it does. There are definitely some things that are not very fiscally responsible about New York State's Medicaid program. They do, it is an important program. It obviously, like it says in that first bullet, accounts for 35% of safety net hospital revenues. Safety net hospitals are those hospitals in those areas where access that hospital truly provides the access to care. They are that area's safety net. And in those areas, they are providing, Medicaid alone is providing 35% of the revenues. They're providing 40% of health center revenues, covers a quarter of all behavioral health care spending, pays for half of all births in the U.S. So Medicaid is very important to revenue in our health system. And this is an interesting expenditure outlook. So you can see that about half of the people enrolled in Medicaid are children, but almost half of the expenditures here, so half of the people enrolled are children, but almost half of the expenditures are for the disabled. And disabled folks are what are called dual enrolled people, because they are typically enrolled in both Medicare and Medicaid. So they're on both social insurance systems, Medicare and Medicaid. Adults only make up about 16% of, other than disabled adults, but adults only make up about 16%. Obviously, there are concerns about ongoing growth in spending because of more volume, more provider payments, more beneficiaries, etc. So it does continue to be a concern that more spending is ongoing there. CHIP is the Children's Health Insurance Program. The biggest concern with CHIP is that it continues to be funded. There was a time last year where the government said, no, we're not going to fund it any further. We're not going to continue that program, and it was threatened. They did decide to move forward and fund it, but that is not into perpetuity. So who's to say that they don't decide to cut that program? And that really would. Obviously, you can see here 8.1 million children enrolled. That would be a travesty if those kids couldn't have coverage, because those kids, that's how they get their well care. Their immunizations. It truly would be a travesty if those kids lost their coverage. I'm not going to go through these slides. It talks about TRICARE. I've already spent enough time. Maybe we'll talk about them on Thursday. But this talks about TRICARE and CHAMPUS, which is the coverage, or CHAMP VA, the coverage for military. But and there's a bit in here about the uninsured too. So maybe we'll spend some time talking about that Thursday morning. But I've talked enough today. So that'll wrap it up for today. We'll talk about the rest of those on Thursday morning. And then we'll talk about the info from Chapter 10 is a bit less voluminous. So because it's the basic finance things, and most of those are covered in the finance class. So we just do a real basic run through. So thank you for accommodating my needs for tomorrow morning, and I do appreciate it. And I will see everyone on Thursday. Thanks a lot.